What is the laptop? Speaker not.
Good evening, Dr. Vadli Ammai, as well as Dr. Hello, good evening, Dr. Veerasamy. Good evening, Dr. Veerasamy.
Good evening, sir. Good evening, sir.
Nice to see you again.
Good evening, sir. Nice, sir. Nice to see you again.
Yeah, one of
Am
your
audible?
junior MDPG from Australia will be watching you. He wanted to watch. He's now in India in Trivandrum for neonatology.
Oh,
I asked him to join, and he'll be watching as an observer.
Good, sir.
Dr. Gopinath.
Dr. Gopinath, MS Gopinath.
Yeah, Kannan's batchmate. Kannan and Geetana's batchmate.
Oh, we did MD together, both of us.
Yeah. So he is in India now. And he'll be coming to Madurai in another tomorrow. So
Okay.
I just happened to see him in the Jipmar alumni neonatology. They have sent photos. Then I talked to him. He did senior residency with in Jipmar for 3 years before he went to do neurology DM.
He was in Japan, sir?
Yeah. All three of them was there. Mohanath, Nikitanath, as well as PRJ Kannan, they were with us.
Good.
I was privileged to have their guidance in running the department.
Good, sir. Still, you are very
He gave
active,
a lot
sir.
of positive suggestions.
You're very active, sir.
Hello, Rajendran sir. வணக்கம்.
வணக்கம்.
உங்களை பார்த்தாலே உச்சக்கட்டத்துக்கு போகிறது. ஆனந்தம்.
என்னமோ சொல்றீங்க சார்.
நான் வந்து மாதிரிலாம் சொல்ல மாட்டேன் சார். வாயில ஒண்ணு மனசுல ஒண்ணு வாயில ஒண்ணு வச்சு பேச மாட்டேன். பட்டுன்னு சொல்லிடுவேன். அதனாலே ஐ அம் நாட் வெரி பாப்புலர்.
இல்லைங்க சார், அதனால தான் நீங்க பாப்புலர். சார் வேலுசாமி சார், வெல்கம்.
Yes sir, good evening sir. Good evening sir. Nice to see you sir.
Yes sir, welcome sir.
Rajendran
சார் சொல்லுங்க சார்.
One of our Velusamy is this thing, batchmate of this thing. He is a neurologist in Australia. He did MD pediatrics. So he has come for neonatology meet in Kerala, and now because he knows Velusamy, I asked him to this Tirumurugan also was there neonatology meet. So I asked him, because they are very good friends. I asked in any case of hemiplegia, next time presentation you can invite him as this thing, the presentative this thing,
Sir, great sir, great.
He has done DM in All India Institute of Medical Science. He was with me as senior resident after MBBS MD from Rajaji Medical College, Madurai.
Thank you sir. Thank you.
Brilliant man.
Thank you sir. Like you sir. சார் உங்க மாதிரியே பிரில்லியன்ட் சார்.
ஐயோ, அவரை போட்டு விட்டு தாக்குறீங்களே. மலைக்கும் மடுவுக்கும் ஐயோ, அவர் என்ன பிரில்லியன்ட் மேன். You will be surprised that all three of them from Rajaji passed in the same year, and they came and joined JIPMER as senior resident. I was blessed, and I had their guidance, positive guidance and inputs in running the department.
டாக்டர் வள்ளியம்மை,
Yes sir.
ஸ்கிரீனை ஷேர் பண்ணி செக் பண்ணிக்குமா?
Okay sir.
ஓகே. இல்ல கலையரசியா வள்ளியம்மை ரெண்டு இதுல இருக்கீங்கப்பா?
Yes sir, we both in one lab.
ஓகே. ஓகே, ரைட்.
Yes.
ஓகேங்க, ஸ்டாப் பண்ணிடுங்க.
Thank you.
மேடம் ராஜ் மேடம் ஜாயின் பண்ணிட்டாங்களா? இன்ஃபார்ம் மேடமா டாக்டர் ராஜி மேடம்.
Good evening sir. Good evening sir.
மேடம் குட் ஈவினிங். உங்களுக்கு கேமரா கொஞ்சம் வீக்கா இருக்கு.
Good evening. Camera sir, one second sir.
உங்களுக்கு வீடியோ கொஞ்சம்
மேடம். வள்ளியம்மையம்மா வணக்கம்.
Good evening sir.
Good evening.
Good evening sir.
மேடம் குட் ஈவினிங் மேடம். ராஜி மேடம்
Good evening sir. Good evening sir.
Good evening
Sir,
madam.
okay, sir, video. Good evening sir.
Dr. Raj.
Okay sir. Sir, good evening, Velusamy
Good
sir.
evening. Yes, nice seeing you madam.
Hello sir, nice seeing
Hello.
you sir. After a long time.
சங்கீதா மேடம் ஜாயின் பண்ணி நினைக்கிறேன். டாக்டர் சங்கீதா.
Sir.
Sir, good evening. I have joined, sir.
Good evening, madam. Good
Madam,
evening.
above there are 3 dots. You just click and name yourself, Raji.
Oh, sure.
டாக்டர் சங்கீதா எதுல இருக்கீங்க?
Sir, can you hear me?
உங்களுக்கு அது இது காணா உங்களுக்கு
Good
நேம்.
evening, Dr. Ramesh, President Ramesh Babu sir.
Good evening, sir. Good evening, Srinivasan sir. Good evening.
டாக்டர் சங்கீதா
Good
வெல்கம்.
evening, Dr. Ramesh Babu.
Good evening, sir. Velusamy sir,
Good evening.
86 Stanley.
Yes.
நீங்க எனக்கு immediate senior. ஞாபகம் இருக்குங்களா?
Yeah, I remember you.
சரிங்க சார், சரிங்க சார்.
I remember you. Nice to see you.
Pediatrics முடிச்சது adult DM neuro
Gopal
பண்ணிட்டீங்களா?
sir.
Yeah,
Good
yeah,
evening, Gopal
yes,
sir.
yes.
Good evening.
Good evening, Dr. Janani.
Welcome.
Good evening.
Good evening,
ரொம்ப
Janani
tired
madam. Good evening, Gopal.
Good evening.
நம்ம செஞ்சுரி போட்டிக்கலாம் இன்னைக்கு.
ஒண்ணும் போடல.
கோபால பார்த்தானே இன்னும் கொஞ்சம் ஆனந்தம் அதிகமாகுது சார்.
சார் என்னன்னா
Candidates எல்லாம் ஜாயின் பண்ணிட்டாங்களா ராஜேந்திரன்?
ஜாயின் பண்ணிட்டாங்க, எல்லாம் ஜாயின் பண்ணிட்டாங்க.
She doesn't this thing, you know, just we have to see her only. Yeah, see, she already mentioned. Good evening all.
ராஜேந்திரன் சார் ஸ்டார்ட் பண்ணலாமா?
பண்ணிடலாங்க. Good evening to everybody. On behalf of IAP TNC, I welcome one and all. And first, we'll start with pediatrician prayer by our president, Dr. Kobal Subramaniam.
for this PhD program on pediatrics. குழந்தை மருத்துவனை நிறைந்துதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயிலும் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்பு என்பதை பணிவுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவர்கள் குடும்பத்தினருக்கும் அவர்களின் சமுதாய பிடிமுறை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம் கற்றல் ஈகை அன்பு அமைதி ஆகியவற்றின் தூதுகளால் என்று விருப்பமாக நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத காரணத்தை ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழலும் நேரங்களிலும் அனைத்து மக்களுக்கு கொடுத்தார்கள். நன்றி.
Thank you, Dr. Kobal. Now I request our dynamic president, Dr. Ramesh Babu, to deliver a presidential address.
Good evening all. Respected Secretary Dr. Rajendran sir and Dr. Treasurer Dr. Gopal sir, the past president of our IAP TNSC Dr. Ismail and President-elect Dr. Suresh Baran sir, office bearers of IAP TNSC, and the judges, respected judges, Dr. Janani madam, Dr. Srinivasan sir, Dr. Rama madam, Dr. Ramesh sir, and Dr. PRC sir. Today's chairperson is my senior Dr. Velusamy sir, and the moderators Dr. Sangeeta madam and Dr. Raji madam, and the delegates who are all attending this PG teaching program on neurology. That is week to peak in weeks. Interesting topic title they have given by the Tanjore Medical College students. At this juncture, I want to congratulate the postgraduates of Tanjore Medical College. Last week, 10 of their postgraduates become member of IAP associate life members. I request other medical colleges also, faculties of other medical colleges also, to motivate their postgraduates to become members of IAP, as well as the pediatricians who are not yet become IAP members should be motivated and enrolled in our IAP fold. I want to congratulate Dr. Rajendran for tirelessly conducting alternate weeks for postgraduates and undergraduates this teaching program for the past 3 years. Thank you, Dr. Rajendran. With this short note, I am handing over to Dr. Rajendran to carry out the proceedings further. Thank you.
Thank you, our President. Respected our dynamic President, Dr. Ramesh Babu, and the President-elect, Dr. Suresh Babu, President 2021, Dr. Ismail, and Treasurer, Dr. Kobal Subramaniam, and Vice President, Dr. Annamalai Vijayaraghavan, and Editor, Dr. Dakshani, and AAA, Dr. Thirumurugan Sarani, Joint Secretary, J. Balasubramaniam, other central as well as state EB members, and on behalf of IAP TNC, I welcome one and all. And first, I welcome our chairperson, Dr. Yes, Velusamy sir, he is a professor and HOD of neurology, Government Kilpak Medical College, Chennai. I welcome Dr. Velusamy sir, and I welcome today's moderators, Dr. Sankira Yoganathan. She is a professor of pediatric neurology, Department of Neurological Science, Christian Medical College, Vellore, and she is having a renowned faculty all over India. And I welcome Dr. Sangita, and I welcome Dr. R. Raji, Associate Professor of Pediatrics at Tanjavur Medical College, Tanjavur. I welcome Madam. On behalf of IAP TNS, I welcome all judges, Dr. Janani Shankar, Dr. P. Ramachandran sir, Dr. S. Ramesh, Dr. Rama Chandramohan, Dr. S. Srinivasan sir. So I welcome all the students, postgraduates from Tanjavur Medical College, Dr. Valliyamai, Dr. Kalai Arasi, Dr. Sai Surya from Tanjavur Medical College. On behalf of IAP TNS, welcome all the postgraduates all over India and teachers to participate for this case presentation. And once again, I welcome one and all. Now I hand out to our chairperson, Dr. S. Velusamy sir, to proceed further.
Yep. Good evening, everyone. At the outset, I'd like to thank the IAP Tamil Nadu chapter for giving me this opportunity. Today, amongst us, we have got the respected judges, all our senior pundits in pediatrics. My respects to all the judges, and we'll start the session. I request the presenter, Dr. Valliyamai from Tanjore Medical College, to present the case.
Yeah, Dr. Valliyamai, please share your slides. And Dr. Sangita, a few words. Dr. Sangita.
Good evening, sir. Thank you for the kind introduction. My sincere thanks to the IAP and the organizing members for giving me this opportunity. We can start the session, sir.
Yeah, Dr. Valliyamai, please share your slide. Dr. Raji Madam, please tell you.
Slides.
Yes, sir. On behalf of Department of Pediatrics, IAP, Tanjavur.
Valliyamai, நீங்க ஸ்லைட் ஷேர் பண்ணுங்கமா.
Slides not sharing, sir.
Valliyamai.
Yes.
Valliyamai, can you hear me?
Yes, sir. Slides not sharing, sir.
இல்ல கொஞ்ச நேரத்துக்குள்ள பண்ணீங்களாமா? அதே மாதிரி தான்.
Yes.
Sweta, can you help her? Hello, Sweta? Yeah. Sweta, can you help her? Sweta?
Slide show.
Yeah, now you are visible, doctor. Go for a full screen.
Sir, is the slides visible, sir?
Yes, yes.
Yeah, you have to go for a full screen.
Okay.
Yeah, proceed. Yeah, good.
Doctors, are you able to see my slides?
Yeah.
Hello? Yeah, I'm sharing the screen, doctor.
Yeah, you can go for a full screen. Yeah, now, yeah, we can see. Yeah. Yeah, you can start, Ma. Valliyamai, you can start.
Yes, sir. Good evening to all. 8 years old girl hailing from Kadalur, informant mother whose reliability is bad, came with complaints of pain over both lower limbs for the past 2 days. Inability to use both lower and upper limbs for the past 2 days. History of presenting illness. 2
Yes,
days.
excuse me, your slides are not moving.
Swetha, next slide.
Doctor, kindly mention when to move to the next slide.
Ma Valliyamai.
Kindly mention to me when to move.
Yeah.
Okay, ma'am. History of presenting illness. 2 days ago, child went to sleep normally. Next morning, on waking up, she complained of pain in both lower limbs. The pain was dull aching, intermittent type. It was started from lower back and radiated to thighs and lower limbs. There was no aggravating and relieving factors. Next slide, ma'am. On the same day, with the pain, the child tried to get up from bed, but she could only lift her head off the pillow. So she called her mother for help. With her mother's help, she was able to sit in bed with support. She was able to move the legs sideways in bed, but she could not lift them off the bed. She was not able to stand even with support also. At that time, mother noticed the limbs to be flail. On the same day, she was able to eat normally, able to hold a tumbler and comb her hair normally. Next slide, ma'am. Sir, am I audible?
You're audible, but your slides are not synchronized with your presentation.
Slides share.
Valliyamai.
Yes, sir.
Valliyamai, if you are actually that DIP, they are sharing the slide, okay?
Okay.
You have to see that slide, they are only sharing the slide, you have to tell, next means you have to tell. Hello?
Yes, sir.
Can you see that DIP slide, no?
Yes, sir.
Yeah. So that now actually it is a day 1, 8 a.m. only that slide is there.
Yes, sir. On day 1 of illness, she tried to get up from bed. Okay. On the same.
Yeah. If you want next slide, Mitch, please tell next.
Okay, so next slide. Next slide, ma'am. On the same day evening, she was taken to a private hospital by her parents. She was admitted there and treated with oral drugs. There was no change in weakness during that night. Next day, child was referred to a higher center, but they went home. On the same day afternoon, in her home, she had, ma'am, previous slide. Previous slide, ma'am. She had difficulty in sitting even with support. She was fed by the mother because she had difficulty in eating and mixing food on her own. But she was able to swallow both liquids and solids without any difficulty. She was able to lift the arm above the shoulder with difficulty, but she was not able to lift the arm above the head for combing her hair. Next slide, ma'am. On day 3 of illness in the morning, she was not able to lift the head from bed, and also she had change in voice in the form of reduction in voice volume. However, her comprehension was good and her words were clear. At the time, there was no history of nasal twang, nasal regurgitation, pooling of secretions, and also there was no history of difficulty in breathing. Then the child was brought to our hospital on day 3 of illness with the above mentioned complaints. Next slide, ma'am. No history of fever at the onset of illness. No history of loose stools prior to the onset of illness. No variation or fluctuation in weakness or fatigability. No history of headache, seizures, vomiting, and altered sensorium. No history of recent IM injection or recent vaccination or recent travel and recent trauma. Next slide, ma'am. No history suggestive of snake bite, insect bite, and dog bite. No history of toxin exposure. No history of abdominal pain or change in color of urine. No history of throat pain. No history of rash, joint pain. No history of ingestion of canned food substances. Next slide. No history of blurring of vision. No history of drooping of eyelids or double vision or restriction of eyeball movements. No history of difficulty in chewing. No history of difficulty in closing the eyes while sleeping. No history of difficulty in blowing. No history of difficulty in hearing. No history of difficulty in swallowing, nasal regurgitation or nasal twang. Next slide, ma'am. No history of difficulty in turning neck from side to side. No history of deviation of tongue to one side. She was able to appreciate the presence of clothes on her body. She was able to differentiate between warmth and cold. There was no history of involuntary movements, no history of bowel and bladder disturbances, no history of abnormal sweating, no history of flushing of face and extremities, no history of palpitation, no history of giddiness. Past history. History of fever with running nose 2 weeks prior to the onset of illness. Fever lasted for 1 day, which was low grade, intermittent type. She taken medications and the fever subsided within 1 day. There was no history of previous similar episodes, no history of drug intake for any chronic illness. Antenatal, natal and postnatal period was uneventful. Next slide. Developmental history. Developmentally normal child, studies in 4th standard, average scholastic performance. Immunization history, she was immunized appropriate for age, last immunized at 5 years of age. Nutritional history, the expected kilocalorie was 1540 and the deficit here is 240 kilocalorie. Expected protein is 22 gram and the deficit here is 2 gram per day. Family history, first order child born to 3rd degree consanguineous marriage parents. There was no history of similar illness in family and there was no history of contact with TB. Next slide. Socioeconomic history, father 6th standard farmer, mother illiterate and housewife, a nuclear family, no family description, income per month is 6,000, Paka, own house, rooms with separate kitchen and toilet, pipe water supply by municipal corporation. According to modified Kuppaswamy scale, belongs to class 3, that is lower middle class.
Valli Ammai, what were your chief complaints? You said a child was brought with a history of pain involving both the legs. And what was the next presenting complaint?
Inability to use both lower and upper limbs for past 2 days, ma'am.
So was that the presenting complaint which the parents stated, or inability to walk?
Inability to walk, ma'am, actually.
So presenting complaint should be in what exactly they describe. So in the history of present illness, you said initially she had difficulty on awakening from sleep. They found that she cannot weight bear and she cannot walk. And did she have any difficulty in rolling over in the bed? Was there any truncal weakness at that time?
No, ma'am. Initially, there was no difficulty in rolling over the bed.
And you said she was able to sit with support on the day one. With support is with back support or with her own arm support?
No, ma'am, with her mother's back support only.
So she had truncal weakness at presentation.
Yes,
so the first 24 hours. And also she next 24 hours, she progressed to involve the upper limb as well. Was there any diurnal variation of the weakness or was there any reported fatigability?
No, ma'am. There was no diurnal variation or fluctuation in weakness.
Symptoms, okay. And you said that the pain was there only in the lower limbs. What kind? You said it's a dull aching intermittent pain. Was it associated with any altered color of urine or anything?
No, ma'am. There was no history of change in color of urine.
What change in color of urine you asked for?
Reddish.
For?
Porphyria, ma'am. And
Porphyria.
also rhabdomyolysis.
So myoglobinuria you need to ask, and for the acute intermittent porphyria, you have to specifically ask for the color of the urine. It's not typically red. Huh?
Yes, ma'am.
So what other, after the presentation of the motor symptoms, you have to screen the neuro axis before going in for the etiology assessment history. So you have given all the history, but the flow should be like you have to elaborate the history of presenting illness, and that first the motor weakness description should be there. And then after that, the screening of neuroaxis, like what other sites of neuroaxis involvement. You have already discussed that, but it has to be in order. So cranial nerve history, you have told, autonomic nervous system involvement, you have mentioned, sensory disturbances, bowel bladder involvement, and cerebellar involvement. So history related to all the different sites of the neuroaxis has to come first before going on to the etiology history. So the etiology history, what all you said, one was exposure to toxins. And what specific toxins you asked for?
Since father is a former, more chance for OPC like poisoning and lead and arsenic poisoning also.
There is, but you said they are from the lower socio-economic status, and there are no industries nearby their areas. So like exposure to heavy metals would be less likely. Yes, so OPC poisoning, yeah. You were also mentioning about the bites, insect bites. What insect bites specifically did you ask for?
Any tick bite for tick paralysis.
Okay. And was there any exposure to COVID patients? You have mentioned about the exposure to TB cases, but in this pertaining particular patient, exposure to COVID cases?
No exposure to COVID patients, ma'am.
Okay. And did she have any previous similar episodes?
No, ma'am. There was no history of previous similar episodes.
Okay, sure. I'll proceed with summary.
Okay. 8-year-old female child with acute onset of flaccid weakness, which is bilateral, symmetrical, and ascending, started initially from both lower limbs, then progressed to involve the trunk, upper limbs, and neck, with both proximal and distal muscles involvement, with hypophonia, with sensory symptoms in the form of pain, without autonomic disturbances or respiratory difficulty, with history of antecedent respiratory tract infection.
Dr. Valli,
Yes, sir.
Just analyze the symptoms one by one. You analyze the symptoms. The first symptom is pain.
Pains.
You analyze the symptom. Analyze the pain symptom first.
Okay, sir. From the history of pain alone, it can be a radicular type of pain or myopathic pain or neuropathic pain, sir. From pain alone, it is very difficult to say it is only due to radicular or neuropathic pain, sir.
So
Because,
what is the character of radicular pain?
In radicular type of pain, the pain is sharp, shooting in nature.
Yes.
From back to involving the lower legs also.
Yes, sharp shooting pain, radiating pain, aggravated on certain maneuvers, coughing, sneezing, all those maneuvers. But here you mentioned it as dull aching pain.
Actually, the child was not able to correctly define the nature of character of pain, sir.
Okay, so what could be the reason for pain? Is it a radicular pain or a neuropathic pain with this history? Or is it a muscle pain?
It can be radicular or muscle pain, sir. If we combine the pain and weakness, it can be due to radicular or neuropathic pain, sir. Because in muscular pain, there will be only proximal muscle weakness only, not involving both the proximal and distal muscles. So it can be a radicular and neuropathic pain, sir.
Okay, so muscle pain will not be radiating. So you told radiating pain as well as dull aching pain. So it may be radicular pain as well as maybe a neuropathic pain may be there. Yes. Okay, what's the next symptom?
Next symptom is inability to use both lower and upper limbs for the past 2 days, sir.
No, she got up from sleep and she had pain.
Yes,
so what happened the previous night? What happened? She was okay.
2 days back, she was okay, sir. She went to sleep normally.
So what did she take for her dinner the previous night?
As usual, normal dinner only, sir.
Normal dinner. What is the relevance here? Both
Sir,
her food.
in case of any high carbohydrate intake, there will be periodic paralysis also will occur, sir.
Yes. So one is the periodic paralysis, high carbohydrate food intake can precipitate to periodic paralysis, hypokalemic paralysis. Second is the canned food. You told us some canned food and honey intake. Okay. Okay, proceed.
Valli, ma'am.
Yes, ma'am.
You said first pain, the child was normal, went to bed at night, and when she woke up, she had the pain, following which she had got weakness. Generally, in this condition, if there is pain and next weakness, what will you think of? Usually in what to say, in village areas, usually they come generalized weakness preceded with pain.
And also you have to mention whether she has slept inside her house or outside the house.
Outside the house, no? What do you think?
Any snake bite history?
Snake bite also we should have in our mind, right?
Yes, ma'am.
So usually how does it present now? Snake bite?
In a case of neurotoxic snake bite, if it is a crime, from the patient history, there will be no history of any bite. They can present with only abdominal pain and weakness. In evaluation only, we can find out.
Now, what will be the characteristic feature? Apart from your weakness and pain?
Yes,
Any
ma'am.
particular?
Drooping of eyelids.
Yeah, that's what. It would have manifested with drooping also, no?
Yes,
so that also we should have in our mind. Okay, sudden child was normal, went to sleep and got up, means immediately that also we have to rule out because treatment will vary, right?
Yes, ma'am.
Okay, you can proceed.
What's the next symptom?
Sir, symptom is only pain and inability to use both lower and upper limbs, sir.
The pain, you have to tell little more how where it is radiating. Whether it's radiating anterior aspect of lower limb or posterior aspect over the thigh or leg, all those things you have to mention to say it is a radicular pain. Okay, the next symptom is difficulty in walking, no?
Yes, sir.
Inability to use her lower limbs.
Yes, sir.
Yeah. So lower limbs as well as upper limb?
Initially started in lower limb, sir. On day 2 of illness only, she had upper limb weakness also, sir.
Okay, okay. So what could be the, where do you localize the lesion for the weakness?
Since it is a flaccid type of weakness, the weakness may be due to probably element types. Then we can localize the lesion at the level of element, whether it is anterior horn cell, nerve root, nerve, neuromuscular junction, or muscle. But here the characteristic finding of weaknesses symmetrical. Yes, ma'am.
So 1 second, sir. Actually, the presenters have been in that not in the panelist list, sir. So she is not able to share the slide. Is it possible, sir?
She has.
They already received email link, madam. They can just open it. They can join.
That's what they have tried, but it is not in that mode they were told, sir. So they are reading it from the.
No, actually, they have to join from the panelist link, but already.
Panelist, yes, sir, yes, sir. Panelist link only. But
yeah, they have to throw panelist link. No, they have to join.
Sir. Okay, sir.
Sweda, please send the following panelist link once again. Okay. Right. Yeah, please proceed.
Probably
you say, yeah, it is a lower motor neuron weakness because it's a flaccid weakness you're saying.
Weakness, yes.
Okay, if it is a lower motor neuron weakness, where is the site of the lesion?
Probably the lesion is at the level of nerve roots, sir.
You're saying it is in the nerve root.
Yes.
Okay, why not in the muscle?
If it is in the level of muscle, the weakness is only symmetrical proximal muscle weakness. Nerve root lesion, and also in the involvement of muscle lesion, there will be only motor weakness only, no sensory deficit.
No, there is no history-wise. History-wise, there is no sensory deficit. You have not examined sensory system. History-wise, you have to say whether it is due to muscle problem or not.
It is not a muscle problem, sir. In muscle problem, involvement is only proximal muscles.
There is no, here there is no history to suggest there is a distal weakness here.
Yes.
The way you presented, she is able to take her food. You told what do you mean by she is able to take her food normally? That means what? What do you mean by that?
Eat on her own, sir. Distal muscles are not involved, but in day 1, sir, on day 2 of illness, she had difficulty in eating, sir.
Difficulty in eating means difficulty in eating could be due to difficulty in chewing, difficulty in swallowing, difficulty in mixing food.
Difficulty in mixing and eating food, sir.
Difficulty in mixing food.
Yes,
okay, what muscles are involved in mixing food? You told her she is able to hold a glass, no? Hold a tumbler.
Yes, sir. She was able to hold a tumbler. Distal muscles.
So that means she was able to hold, no? Initially, she was able to. Okay.
Was not able to hold a tumbler, sir.
Okay. For holding tumbler, which muscle is? What is the muscle involved in holding the glass? Okay, it's a flexus. For mixing food.
Extensors.
No. For mixing food, there's lumbricals, intraossei, or okay. So history-wise, there is some distal weakness as well as proximal weakness in upper limb, and in the lower limb, there is a history for proximal weakness only.
Yes.
Distal muscle weakness, so there is no history.
Yes.
Okay. So what is the point against muscle disease here? You told some pain, no? Pain is a radicular pain.
Radicular pain, sir.
Pain from back radiates to both the thighs and the legs. So it's a radicular pain.
It's not radiating type, sir.
Yeah.
It's localized to a particular muscle area.
Okay. So that is a point for maybe a radicular problem. It's not a muscle disease. Okay. What's the next neuroaxis? Neuromuscular junction. Could it be in the neuromuscular junction?
No, sir. There was no history of any diurnal variation or fluctuating in weakness and also critical bleeding.
No diurnal variation or fluctuation, and no history to suggest involvement of extraocular muscles. No bulbar and no extraocular muscle involvement as history-wise.
Yes, sir.
Okay, so it is unlikely to be in the neuromuscular junction. Is it in the peripheral nerve?
No, sir, it is not in the peripheral nerve, because if it is in the peripheral nerve involvement, the weakness will be more distal muscle weaknesses predominant, and also there will be a blunting of sensation in distal areas.
No, if sensory symptoms are there, yes, it is for peripheral nerve. Absence doesn't rule out the peripheral nerve involvement. Pure motor neuropathy is there.
Yes, sir.
So neuropathy may be either sensory or motor or both sensory motor. So,
but in motor neuropathy, the weakness is mainly in this area.
Yeah, but lower limbs, we don't know about the distal weakness. Upper limb, she has got distal weakness. So peripheral nerve, yeah, we cannot rule out a nerve, peripheral nerve involvement here. Okay, it could be in the peripheral nerve, and then radical, yes, there is a radicular pain. Proximal weakness is there. So radicular involvement is there. Plus minus nerve. Okay, radicular neuropathy. And whether it is in the anterior horn cell, what is the point against anterior horn cell disease here?
If it is in the anterior horn cell area, the lesion will be present as it is asymmetrical involvement mainly, and it also a pure motor weakness.
Yeah, it's only pure motor. There will not be any radicular pain like this, and usually asymmetrical and patchy involvement. That is acute anterior horn cell disease. Chronic anterior horn cell disease, you can get fasciculations, wasting.
Yes.
In chronic anterior horn cell disease. Name one chronic anterior horn cell disease.
Spinomuscular atrophy.
Very good, very good. Okay. Okay. So now where do you localize the problem?
Nerve root or nerve cell.
So definitely root is there.
Yes, sir.
Plus minus no. Okay. So maybe radiculoneuropathy or radiculopathy, polyradiculopathy.
Yes.
Okay. So what is another symptom? About this weakness, she has got another symptom. What is the other symptom?
Fever, history of fever 2 weeks back prior to the onset.
No. The present history. One is weakness, pain, weakness, and then
it's a change in voice.
Change in voice.
Volume.
Okay. So where is the problem? Where is the problem for the
cranial nerve involvement might be there, sir. 10th cranial nerve involvement.
10th cranial nerve involvement. But she has no difficulty in swallowing. How to explain that?
Mild transient involvement might be there, sir, in bulbar area.
Maybe the pharyngeal branch, laryngeal branches are there for vagus nerve.
Yes.
Maybe pharyngeal branch is spared, only laryngeal branches.
Laryngeal branches.
Yeah.
Yes.
May be involved. Okay, any other symptom? Any other symptoms? Pain, weakness, and hypophonia. Okay.
And change in voice.
Okay, change in voice.
Yes.
Okay. So your presentation should be in order. As Dr. Sangeeta mentioned, you have to describe the presenting complaint first. Presenting complaint is pain and then weakness. Weakness, you have to elaborate on the weakness, whether it's lower limb weakness, upper limb weakness, proximal history suggestive of any proximal muscle involvement, distal muscle involvement, and history suggestive of any respiratory breathing difficulty, respiratory muscle involvement, neck muscle involvement, trunk muscle involvement, whether any diurnal variation is there or not. All those things you have to mention it. And then history suggestive of any higher function involvement, cranial involvement, and other involuntary movements, everything you have to mention. And then you have to go back to the etiological history. Fever at the onset, loose stools, toxin exposure, snake bite, dog bite, all those things you have to mention later. Presenting complaint, first you have to elaborate on the presenting complaint. So that with that history, we have to analyze that history. With the symptoms, you have to analyze the symptoms. So it should be in the order. Etiological thing should be mentioned later.
Okay.
Okay. So why do you want to know about the higher function involvement here?
To rule out the cortical involvement, central causes like ADEM.
ADEM, yes.
Yes.
Any other thing?
Poliomyelitis, encephalitic stage also.
Yeah, poliomyelitis, polioencephalitis, yes, very good. Next one. Any other?
Bickerstaff encephalitis variant of GBS.
Yeah, Bickerstaff encephalitis, yes. Any other? Porphyrias?
Yes, sir.
Yeah, porphyria patients can have behavioral issues, some psychiatric issues will be there. And patient can have even hyponatremia and can cause encephalopathy. Okay. Dr. Sangeeta?
Yes, sir.
Yeah. Anything else in the history?
I think she has covered up most. What are the causes for the acute anterior horn cell involvement? You mentioned chronic is SMA. Acute, can you mention a few causes?
Poliomyelitis, non-polio enteroviral infection. That's acute flaccid myelitis.
Yes. What else?
Anterior spinal artery syndrome.
So infectious causes are polio and non-polio enteroviruses, Zika virus, West Nile virus, CMV,
J.
and even COVID infection.
Yes.
So what are the causes for acute causes for peripheral nerve involvement?
Peripheral nerve infectious causes like cytomegalovirus, diphtheria, syphilis, and drug intake causes like chloramphenicol, isoniazid drug intake, ethambutol, ART drug intake. Nutritional causes like B1, B12 deficiency, and then immune-mediated GBS also affect the nerve also. Then metabolic causes like porphyria.
Okay, inflammatory, GBS or acute presentation of CIDP.
Yes,
nutritional, usually they will not be hyperacute like this in this, as you see in this patient. Usually they will be like subacute or chronic presentation. Traumatic neuropathies, you can have acute presentation. Infection is one, metabolic is another. Yes, metabolic, among the metabolic, porphyria you said, tyrosinemias, mitochondrial cytopathies can also have like presentations with like neuropathic crisis. Neuromuscular junction, what are the acute causes?
Snake bite, myasthenic crisis, botulism, OPC poisoning, tick paralysis.
Okay. Myasthenia, usually with the myasthenic crisis, they can have this kind of hyperacute or acute presentation. Otherwise, usually it is like subacute and then progressive. Or with the typical diurnal variation and fatigability. Muscle, what are the acute causes?
Inflammatory myositis like polymyositis and dermatomyositis.
What is very common? See, you said there was a viral illness 2 weeks prior. So viral myositis is more common rather than your other causes like what you mentioned, inflammatory myositis. It's not very common in inflammatory myositis or a metabolic myopathy presenting with crisis. The most common what you see in your practice is viral myositis.
Viral myositis.
Okay, please proceed.
You told about the previous history, no? No
Yes,
history of similar episode in the past.
yes, sir.
So what are the causes for recurrent weakness, recurrent paraparesis or recurrent quadriparesis?
Sir, in periodic paralysis, there will be chance for recurrence, and also in myasthenic crisis like illness, rarely recurrent GBS is also there.
Recurrent GBS, periodic paralysis, yes.
Myasthenic crisis.
Myasthenic crisis. Okay, porphyrias.
Yes, sir.
Recurrent demyelinating myelopathies. Demyelinating myelopathies can recur. And other spinal cord lesions, spinal cord, AV malformations, CV junction anomalies, you can get recurrent weakness. And even mitochondrial diseases, mitochondrial myopathies. And family history.
Periodic paralysis can occur in families.
Okay.
And also muscular dystrophy.
No, acute weakness.
Periodic paralysis.
Yeah, periodic paralysis. Porphyrias.
All your inherited metabolic causes, you said, no? Inherited neuropathies and inherited metabolic myopathies, they can present with high acute presentations.
And even toxin exposure. Toxin exposure in the family, you can get simultaneous exposure of OPC poison, you can get. And you mentioned about fever at the onset, no history of fever at the onset.
Yes, sir.
So if there is fever at the onset, what will you think?
Non-polio enteroviral infection like acute flaccid myelitis, epidural abscess, viral myositis, polio, then POTS pain in front.
Okay. Okay, good.
Yes, ma'am.
Under flaccid, whenever a child lands up to you with acute flaccid paralysis, no? What are all the things which will run into your mind? What are the differential diagnosis, no? What you think of? Based on the anatomical lesion you have given one classification. Apart from things, common things which run in your mind when you see the case.
First, any vascular causes, then inflammatory.
That is based, what I am trying to ask is AFP, what is the common differential diagnosis?
Acute poliomyelitis, transverse myelitis, GBS, traumatic neuritis, isolated Bell's palsy, any transient weakness also.
Transverse myelitis can also manifest like this, no? In an acute onset. Is it
Yes,
possible?
but in
How will
earlier
you
stages,
differentiate, no?
in earlier stages of transverse myelitis, it will present as element type of weakness, that is placid weakness, but there will be but points against to this cases, there will be no bladder involvement at definite sensory level.
So in transverse myelitis, the onset can be acute, number one. Number two, you're telling there might be early bladder involvement.
Bladder involvement.
What else will be there along with this?
Sensory disturbances,
Sensory
below the level of
disturbances.
patient, loss of sensation.
So that stage is called what? What do you call that stage?
Early stages, spinal shock.
That stage is called a spinal shock, right?
Spinal shock.
So next one, the latest stage, how will it manifest?
Ma'am?
Late stage or next stage, how will it manifest, ma'am?
In late stage of transverse myelitis, it can manifest like EMN type of weakness, ma'am. There will be increased tone, reflexes also increase, and plantar will be also extensor.
Okay, so that we have to keep it in our mind because in the early stage it will be mimicking like an element type of patient, right?
Yes, ma'am. Yes.
Okay.
If this case is a myelopathy, where do you localize? If this case is a myelopathy, suppose if this is a myelopathy, where do you localize?
Yeah.
Cervical where?
Above C4, quadriparesis.
Above C3, because you told us neck muscle is weak, no?
Yes.
So neck muscle is weak, so it is above C3.
Hypophonia is also there.
Hypophonia, so maybe the high cervical cord.
Yes.
High cervical cord involving medulla also you can say. But if it is in the medulla, the patient should have difficulty in swallowing also. Okay, so with this history, so you're localized to radical plus minus polyradiculopathy plus minus peripheral now.
Yes.
So what could be the cause?
Since the presenting complaint is symmetrical, bilateral, ascending type of weakness, and also the onset is very rapid, probably it is polyradiculopathy due to Guillain-Barré syndromes.
There is some preceding antecedent, some infection is there, respiratory infection.
Running nose prior to the onset of illness, 2 weeks back presence.
So Guillain-Barré syndrome.
Yes, sir.
Okay. So what are the causes for descending paralysis?
Descending paralysis, post-diphtheritic paralysis, botulism, and also porphyria.
Okay. Okay, so I think you can proceed with examination.
Dr. Velusamy.
Sangeet, yes.
It's Gopinath here.
Yeah, yes.
Yes. With your permission, can I add something?
Sure,
I think the professor wanted.
So, sure, you can share.
To the presenter, I just wanted to ask, rather than placing all the symptoms that the parent has said to a textbook presentation, my viewpoint will be, if somebody has pain, then the next question you will ask is, how did they respond to the pain? So did they give some analgesics, and did it settle the pain? And did the pain disappear when the child was at rest, or did the pain only come on when the child was asked to do something? So that information can help as well.
The pain was not subsided with any analgesics. They were treated on day 1 of illness in private hospital, but the pain was intermittently present on and off, not relieved by any medications.
Yeah.
But
so
it
the
is
question,
not that much severe
yeah.
pain.
So the question will be, how disabling was the pain? Did the child refuse to do anything because of pain? Or so how much did the pain limit the weakness? So sometimes you can have a very painful condition and the child will be very scared to move or weight bear, for example. Let's say if you had arthritis and things like that, then you may not be willing to walk. The other condition that you also think about is juvenile dermatomyositis, where it can be extremely painful and irritable condition, and that will be the reason the child will not walk.
But here, not due to pain, the child was not able to walk. The weakness is more severe than the pain.
Yes. So that's the main thing that you can project, saying in the scheme of things.
As per mother's history, the child was able to move the limbs sideways in bed also, sir. She was not only lift them off the bed.
Also,
So that way you can,
childless
that way you
pain
can eliminate local causes like arthritis or, so that's one thing I wanted to point out. The second thing when weakness happens is, if you're talking about hyperacute onset of weakness, where the weakness happens in just a couple of seconds, then there is not much history that is required. Did it happen that way?
No, sir.
Yeah. So if you think about an 8-year-old, the child could have woken up and said, "Mommy, I could not go to the toilet," or could have woken up and fallen down on the floor and would not been able to get up from the floor and would have asked for mom's help. Something has happened, help me to the toilet. So that's how a natural history would have happened. Isn't it? If you really thought about the story from the mother's side, the way you present, you almost sort of put the information and said, yes, there is proximal weakness and distal weakness. But if you're really presenting the mother's story, you would actually tell what happened. How did the mother find out that she was weak? Did the girl say that I'm not able to move?
Yes, sir. Initially, the child only told to the mother she was not able to get up from bed.
So she needed help to maybe to go to the toilet?
Yes, sir.
Okay.
With the mother's help.
Okay. So when an 8-year-old girl tells mother like that, if you're a parent, what's your reaction? You might be thinking, come on, don't be silly. Isn't it? So they might have made her stand. They might have made her stand on the floor to see what's happening. Did they do that?
Yes, sir. Mother tried to stand the child with her help, but she was not able to stand even with support at that time.
Support. Okay. You brought that out in the history. You brought that out in the presentation. Very good. Very good. Yeah, I think that's important. Yeah. And then you said at that time the upper limbs were working.
Yes, sir. On day 1, only lower limbs are affected. Upper limbs are normal, sir.
So what history did you get to say it was working? Was she was able to eat by herself?
She was able to eat by herself, and also she was able to comb her hair.
Yeah. Okay. That's good. The other thing I wanted to point about hypophonia that you said.
Yes, sir.
Is it because of general weakness that her voice was low or poor?
No, sir, not due to weakness. It can be due to a cranial nerve involvement.
Yeah. But if you think about bulbar weakness,
yes,
can
sir.
you just have one cranial nerve which is affected without having drooling, without having choking? Because normally when you have bulbar weakness of that degree, the child will not be able to maintain the saliva. They'll start drooling.
Pulling off. Yes.
Yeah, pulling of secretions or drooling. And they'll not be able to maintain their own saliva and they'll choke on that.
But in this case, there will be only history of reduction in voice volume, sir. No other history is there.
So when somebody has reduced voice volume, we talked about the larynx, but it can be general weakness as well, isn't it?
Yes, sir, it can be.
Yeah. That was my comments. Thanks, Dr. Velusamy.
Okay. Thank you, Gopinath. And the pain, she didn't have any pain in the upper limbs. She had pain only in the lower limbs. So it's unlikely to be due to some local problem. She had weakness in upper limbs, but she didn't have any pain in the upper limbs. So pain is unlikely to be due to arthritis or any local problem. Okay. Okay, you can proceed with the examination.
Child examined at admission, child lying on the bed with the arms by the side, arms extended at the elbow with palms facing upwards and lower limbs extended at the
Placenta is different?
Yes, sir.
Okay. Your color is
Yes, sir.
okay, okay, present.
Child examined at admission, child lying on the bed with arms by the side, arms extended at the elbow with palms facing upwards and lower limbs extended at knee with abduction at the hip joint and lateral aspect of the feet touching the couch. Child was moderately nourished, conscious, afebrile, no pallor, icterus, cyanosis, clubbing, hidden edema, and lymphadenopathy. No neurocutaneous markers. Vitals, temperature 98.7 degree Fahrenheit in right axilla, pulse rate 86, regular in rhythm, normal in volume, no specific character, held equally in all four limbs, no radioradial, radiofemoral delay. Blood pressure 96/60 millimeter mercury in right upper limb in lying posture. Respiration rate 26, thoracoabdominal pattern. Room air saturation was 98%. Anthropometry. Observed length was 120 centimeter and observed weight was 22 kg and observed BMI was 15.2. All of this comes under within 10th and 8th centile. Head to foot examination. Head normal in size, face no dysmorphism, eyes no ptosis, nystagmus, squint. Oral cavity, no glossitis, cheilitis, angular stomatitis. Neck normal, chest and abdomen normal. Skin pigmentation of knuckles or hyperpigmentation. Nails normal, limbs no deformity. Higher mental functions. Conscious.
Before going to higher mental function, you tell me what for you have seen those in the general examination. You should know the significance of all those things. The previous slide. This is the one. Okay.
Posture itself.
Okay. Next slide.
Vitals.
Okay, respiratory rate is 26. Is it normal for this child or?
It's normal, sir.
Child age is 8 years.
Yes, sir.
Okay. It's normal for this age.
Yes, sir.
Okay. So what else you want to see in the respiration? Respiratory rate, thoraco-abdominal pattern, and then saturation you mentioned. Anything else?
From the history itself, there is involvement of the bulbar weaknesses present, sir. So we have to.
So examination, you have to see something more for respiration. Whether accessory muscles are working or not.
Yes,
is there any paradoxical respiration? Okay. So next. So what for pulse regular in rhythm? You mentioned pulse rate and regular in rhythm. So what do you expect here?
Autonomic disturbances.
Okay. So the child is prone for autonomic disturbances. Okay. Next. So what for the length or height? Length is normal, no? Okay. Okay, if there is a short stature, what will you think?
Central cause of hypotonia, there will be short stature, sir, and developmental delay will be there.
No, in this case, you have to say. Suppose if this child has a short stature, presenting with weakness.
Spinal muscular atrophy.
Hypokalemic paralysis is due to secondary to other causes like renal tubular acidosis. Renal tubular acidosis, and then mitochondrial diseases. Mitochondrial diseases, patient can have short stature. Next slide. Next slide. Next. Dysmorphism, what for?
In case of myopathy, there will be myopathic phases.
Yeah, myopathic phases.
Forced phases in hypothyroidism and Anderson-Tawil syndrome in case of periodic paralysis.
Okay. And even mitochondrial disorders, there will be dysmorphism. Oral cavity, you mentioned no glossitis, cheilitis, ankylostomatitis. What else? Oral cavity means, what about throat? You have not mentioned anything about throat here.
There was no patch.
Yeah, that you have to mention. No? That's very important. No? Diphtheritic neuropathy. Neck is normal. Okay. Skin, no rash.
Firm, apart from patch.
So what rash you look for skin rash?
In case of Lyme's disease, erythema chronicum migraines, and in case of myositis, viral myositis and inflammatory myositis, there will be rashes in dermatomyositis.
Dermatomyositis rashes. Okay, heliotropic rash, Gordon's papules. Okay.
Vasculitic neuropathy, SLE also can present with vascular.
Okay, photosensitive rashes. Where do you get photosensitive rashes?
SLE.
SLE.
Okay. And also in dermatomyositis.
Okay. So what about in porphyria?
Porphyria
cutaneous tarda.
Okay, but in acute intermittent porphyria, usually there will not be any rash.
Yes.
Okay, in other types of porphyria, there will be rashes. Nails. Nail.
In arsenic and lead poisoning, there will be knee strain in arsenic poisoning and
okay.
in lead poisoning.
Okay, good. Okay, good. Go ahead. Proceed.
Higher mental functions: conscious, oriented to time, place, and person, no emotional instability and behavioral disturbances, immediate, recent, and remote memory normal, speech, comprehension and word output was normal, but there is reduction in voice volume. Sleep pattern normal. Cranial nerves examination. First cranial nerve, olfactory nerve, perceives smell in both nostrils separately. Second cranial nerve, optic nerve, visual acuity normal, field of vision normal, color vision normal, fundus normal.
Why did you test for smell here? COVID, yes, good. Okay. Fundus, what do you want to see in fundus?
To look for papilledema.
Papilledema can occur in Guillain-Barré syndrome. What's the reason for papilledema?
Due to rise CS of proteins.
High CS of protein. Yeah, it's due to high CS of protein. Okay.
Anything else you can see, fundus, which can
optic atrophy, ma'am.
If there is optic atrophy,
neuromyelitis optica spectrum disorders, ma'am.
okay.
Don't see optic atrophy in acute phase of neuromyelitis optica spectrum disorder. You see optic neuritis. Okay, ma'am.
Okay. Next.
3/4 and 6th cranial nerves, extraocular movements full, pupils equal in size 3 mm and round, direct and indirect reflex present. 5th cranial nerve, sensation over the face present, and clenching of the teeth.
Why do you want to see pupils Suppose pupils constricted means what will you think? Dilated pupil, what will you think?
Constricted pupil, OPC poisoning, sir.
Okay.
Dilated pupil, diphtheria and botulism, fixed and dilated pupil will be there, sir.
Yeah, botulism. So what about accommodation?
In diphtheria, there will be urgent Robertsonian people, sir. Light reflex absent, accommodation reflex will be preserved.
Accommodation. I think accommodation will be lost in diphtheria. Accommodation will be lost in diphtheria. That's what I think. Subject to correction. Dr. Sangeeta?
Yes, sir.
I think in diphtheria, accommodation will be affected. Accommodation paralysis will be there in diphtheria.
Yes.
Okay. Okay, you have to mention about ptosis here in 3, 4, 6. Okay, next, fifth now. Normal.
Sensationality is present on clenching of the teeth, muscle contraction felt, jaw jerk not present, corneal and conjunctival reflex present. Seventh cranial, wrinkling of the forehead present, able to close the eyes tightly and eyelashes completely buried during sleeping, nasolabial fold present, able to blow the cheeks, no deviation of angle of mouth while smiling. Eighth cranial, bilateral renius and rebustus normal. Ninth and 10th cranials, uvula in midline, palatal movements equal on both sides, gag reflex present, no cooling of secretions. 11th cranial, able to turn the head against resistance and able to shrug the shoulders. 12th cranial.
You have to mention about voice here. Voice volume is reduced. Okay. Okay, proceed. Proceed.
12th cranial, tongue. 12th cranial, tongue, bulk and tone normal. There is no atrophy, fasciculation, and protrusion of the tongue. There is no deviation. Motor system examination. Well, there is no wasting. Arm, forearm, and thigh cuff equal on both sides.
Do you expect wasting here?
No, sir. Substituting an answer.
Okay. Okay, next.
Tone is decreased in all four limbs. Upper limb, both right and left side decreased. Lower limb, both right and left side decreased.
Proceed. Yeah, next.
Cover, best observed, shoulder, undoing, flexion, extension, adduction and abduction on both right and left side, it was 3/5. Elbow, during flexion and extension, it was 3/5 on both sides. Wrist, undoing, flexion and extension, it was 3/5 on both sides. Hip, flexion, undoing, flexion, extension, adduction and abduction, it was 2/5 on both sides. Knee, during flexion and extension, it was 2/5 on both sides. Ankle, during flexion and extension, it was 2/5 on both sides. Finger grip and toe grip was weak, and neck muscles also weak, sir.
You have to start with the neck muscle first. What about trunk muscle?
Also weak. Trunk muscles also weak, sir.
So respiratory muscles.
We couldn't check power for respiratory muscles.
No, you have to mention about any paradoxical respiration, single breath count. You have to.
Yes, sir.
You have to mention about single breath count here, respiratory muscles. So power examination, you have to start with the neck muscle. So neck muscle, trunk muscles, and then respiratory muscles, and then limb muscles.
Yes, sir.
And grip, toe grip, hand grip, you have to mention.
Yes, sir.
Okay. So there is proximal and distal weakness, both are equally involved. Lower limb is more involved than the upper limb.
Yes, sir.
Both proximal and distal equally involved.
Yes, sir.
Okay. So what is this grading called?
MRC grading of power.
MRC grading, yes, good.
reflexes, superficial reflexes, corneal conjunctival reflex present, palatal and gag reflex present, abdominal reflex absent, plantar reflex no response.
What is the afferent for corneal reflex?
Fifth cranial nerve, trigeminal nerves, and afferent seventh cranial nerve, facial nerves.
Good, good. Next.
Deep tendon reflexes, biceps absent on both sides, triceps absent on both sides, supinator absent on both sides, knee and ankle joint absent on both sides. Even after gender 6 maneuvers.
Yes, next.
Sensory system, able to perceive touch, pain, temperature, and vibration signs all over the body. Cortical sensations intact. Cerebellar signs, no nystagmus. Coordination couldn't be tested. Gait couldn't be tested. Spine and cranium normal. Pharyngeal signs not present. Musculoskeletal system, there is no muscle joint tenderness.
Sensory system, joint position sense you have to mention. Joint position sense, touch, pain, temperature, joint position sense, vibration sense. So which tuning fork you use for testing vibration sense?
128 Hz tuning fork.
128 Hz, good. Spine and cranium. Spine, what did you look for? Spine is normal. What did you look for?
Gibbous spine. Craniovertebral anomalies, spinal tenderness in case of hot spine.
Okay, so spinal tenderness, gibbous, any spasm, paraspinal muscle spasm. Yes. What are the meningeal signs?
Neck rigidity, anything through the skin signs.
Okay, good, good.
Can you have meningeal signs in GBS?
No, ma'am.
You can have Kernig's positive, you can have neck rigidity, you can have Brzezinski positive in GBS because of the radiculopathy. Radiculopathy, you can have paraspinal muscle spasm. Because of that, you can have.
Okay.
You didn't mention about involuntary movements in the motor system. Okay.
There is no involuntary movement.
Okay, what about peripheral nerves? So nervous system examination, it's not a central nervous system examination, it is a nervous system examination. Nervous system examination, you have to mention about central nervous system, peripheral nervous system, and autonomic nervous system. And you have to mention about the bladder also, bladder distension is there or not, any other autonomic signs, autonomic nervous system disturbances. The skin, dryness of skin is there, any sweating abnormality was there. All those things you have to mention. So nervous system examination includes peripheral nervous system as well as autonomic nervous system. Okay, you're not mentioned about bladder distension, any sweating abnormalities you didn't mention.
There is no bladder disturbances.
Okay, that you have to mention. Sweating abnormalities and the nerve thickening you have to mention. Okay. Okay, proceed to the next one.
Other system examination. Cardiovascular system, X1 used to hear, no murmur. Respiratory system, bilateral larynx present, no adventitious sounds, single breath form was clean, parabdomen soft, no organomegaly.
So you summarize your examination findings now.
Summary, 8 years old developmentally normal child with acute onset of flaccid progressive weakness, which is symmetrical and ascending from lower limbs to neck, involving proximal and distal muscles with bulbar involvement in the form of hypotonia, with hypotonia, areflexia, and decreased power, with the sensory symptoms in the form of pain without autonomic disturbances involving the nerve roots and nerve.
Okay. So after examination, the finding is hypotonia, areflexia, and quadriplegia, proximal and distal weakness, both upper limbs and lower limbs, lower limb more involved than the upper limb, without any sensory involvement. Now you tell the localization after examination. Anything new? Anything new information we got after examination?
No, sir.
No, nothing new.
History-wise, there is involvement of the bulbar muscle, sir. But in examination, it was normal only, sir. There is no involvement.
There is no involvement clinically, but still patient has got hypophonia. So could be due to laryngeal involvement.
Yeah, the single breath count is also only 15, you said. Hypophonia is also there, and then single breath count is also 15. So there is like she has a rapidly progressive ascending weakness. So chance of impending respiratory failure.
Yes, ma'am.
So why do you want to know about neck muscle weakness here? You told neck muscle is weak, no? History wise, there is neck muscle weakness. Examination wise, there is neck muscle weakness. Why do you want to know about neck muscle weakness here? What is the significance of importance of neck muscle weakness here?
To rule out impending respiratory failure.
Yeah, impending respiratory failure. Neck muscles, the root value for neck muscles are C3, C4. So diaphragm supply is C3, C4, C5. Phrenic nerve C3, C4, C5. So neck muscle weakness, shoulder abduction weakness, all those things indicate that there is a impending respiratory muscle weakness. So this child had impending respiratory muscle weakness, as evidenced by neck muscle weakness. A single breath count is marginally reduced, which is 15. Respiratory rate is 26, maybe. So child had some impending respiratory failure. So after examination, could it be a myelopathy?
No, sir.
There is no sensory involvement.
There is no sensory involvement, no bladder and bowel involvement, sir.
Yeah, no bladder bowel involvement, and there is it's okay. So unlikely to be in the cord. Is it a muscle disease after examination?
No, sir.
So why? What's the point against muscle disease here?
Flaccid paralysis equally involves the proximal and distal muscle weakness, sir. In muscle disease, there will be proximal muscle weakness will be more than distal muscle weakness.
Okay.
Reflexes will be preserved in muscle disease.
Yeah. So reflexes will be preserved in muscle disease. Here, reflexes are absent. Okay. Okay. So what is your diagnosis now?
Diagnosis: neurological deficit, quadriparesis with both proximal and distal motor weakness. Anatomical localization, polyradicular.
You can say quadriplegia. I think power is 2. You told 2, no? 2, 3. So it's okay. Quadriplegia with both proximal and distal weakness. Weakness. It's not a motor weakness. So why do you say motor weakness? Proximal and distal weakness. Okay.
Etiology: inflammatory. Pathology: demyelinating. Diagnosis: Guillain-Barré syndrome.
Okay. Any other differential diagnosis? Diagnosis is Guillain-Barré syndrome. Okay, agreed. Anything else? Any other differential diagnosis you want to rule out or you want to consider? In any case of acute flaccid paralysis, you have to consider, for at least for epidemiological purpose, you have to consider the possibility of poliomyelitis. For epidemiological purpose, you have to consider that possibility and you have to investigate. You have to rule out poliomyelitis. Okay, clinical diagnosis is Guillain-Barré syndrome. Agreed. Yes. So how do you proceed?
The baseline investigations which are done for this child are CBC, sir. The total count was 10,008.
One minute. Anything else, Dr. Sangeeta? Anything you want to add?
I think we have covered up, sir.
Okay. Dr. Raju, madam? Dr. Raji?
Hi, so can you hear me?
Yeah. Anything you want to add? Yeah.
I think she's told everything, so can proceed to investigation.
Dr. Gopinath? Gopinath? I think he has left, it seems. Okay, you proceed.
The investigation panel, sir.
Yeah.
The baseline. The baseline investigation which is done for this child are CBC. Total count was 10,800. Hemoglobin 13. Platelets 2.2.
What's the normal hemoglobin level?
Less than 11 is anemia, sir.
No, 11 what? 11 of what? I think your unit you mentioned is wrong.
Grams, it's not milligrams.
Yeah, you have to mention as gram, gram per deciliter.
Sorry, sir.
Okay.
Platelet was 2.2 lakhs per microliter. Hematocrit was 39%. Lymphocyte was 46%, and neutrophils were 49%. On peripheral smear, it showed normocytic normochromic RBCs and platelets were adequate. RFT, urea was 28 and creatinine 0.6. Electrolyte panel was done and sodium value was 137 milliequivalents per liter. Potassium was 4 milliequivalents per liter and chloride was 111.7 milliequivalents per liter. The serum calcium value was 10.6 milligram per deciliter and CPK value, creatinine phosphokinase value was 106 microgram per liter. Nerve conduction study.
CPK also, I think it's not in micro, it's usually in the units, no?
It's units per liter, yeah.
Yeah, okay.
Nerve conduction study was done for this child. The upper limb and the upper limb examination, both median nerve as well as ulnar nerve was examined. Compound muscle action potential distant latency was prolonged. Amplitude was markedly reduced. Nerve conduction velocity was reduced. Temporal dispersion was plus. Sensory nerve action potential was not obtained and F wave was not obtained. Lower limb, bilateral, peroneal and tibial nerve were examined. Compound muscle action potential distal latency was prolonged. Amplitude was reduced. Nerve conduction velocity was reduced. Temporal dispersion was plus and F wave was not obtained. The inference impression was bilateral sensory motor demyelinating polyradiculoneuropathy.
When did you do nerve conduction study? After how many days after hospitalization?
The second week of illness, we did the nerve conduction study, sir.
Second week. Okay. So if you do in the first week, the initial 1 or 2 days, what will be the findings in nerve conduction study in GBS?
The earliest finding in nerve conduction study is prolongation of F wave latency, sir.
Prolongation of F wave latency, it may be even normal. The first day, day 1 or day 2, nerve conduction study may be normal. So normal nerve conduction study doesn't rule out GBS in the initial few days. It may be entirely normal, or there may be increased F wave latency, or number of F waves may be reduced. Sometimes it may be normal in the initial few days. That you should remember. So normal nerve conduction study doesn't rule out your clinical diagnosis of GBS. So diagnosis of GBS should be a clinical one first. Okay, proceed.
MRI brain and spine was done. There was no evidence of acute infarct or hemorrhage or any space occupying lesions. The CSF analysis was not done in this patient, sir.
So what do you expect?
Why did you do MRI brain?
Ma'am, initially to rule out other demyelinating conditions like ADEM, ma'am.
Child clinically doesn't have encephalopathy.
No,
There are no seizures, and nothing to suggest myelopathy as well. It's a pure like a polyradiculoneuropathy. So ADEM presenting as a pure polyradiculoneuropathy is not a usual presentation, no? So spine, MRI spine, you can say like because it's an element weakness, because if you're localizing it to the anterior horn cell, you can do it for looking at excluding the polio or non-polio enterovirus infection or other viral encephalomyelitis. Or if you're suspecting GBS in MRI spine with the contrast, what can you see? What findings can you observe?
In GBS gadolinium enhancement, in gadolinium contrast, the anterior nerve roots will be enhanced, ma'am.
Nerve root enhancement can be observed, and cauda equina nerve roots can be thickened, and also they can also be enhancing.
Yes, ma'am.
So, but generally you don't do an MRI spine and brain in a child with a classical GBS. CSF analysis, what are the typical findings described, and when are you expected to do CSF analysis in a child with suspected GBS?
In CSF analysis, in GBS, albuminocytological dissociation will be present, ma'am. That is, the protein levels will be more, whereas the cell counts will be less than 5 cells per millimeter cube, ma'am. It is usually done at the end of second week, ma'am. At the second week to third week, ma'am. If it is done in the first week, there are only 50% chance of albuminocytological, less than 50% chance of albuminocytological dissociation, ma'am. If it is done in the second week, there is 75% albuminocytological dissociation can be present. When it is done in the third week, nearly 90% can be present, ma'am.
Okay.
Suppose if cells are increased, protein is also elevated, cells also elevated, what will you think?
Then HIV associated neuropathy, sir.
HIV associated radiculopathy, HIV, CMV, cytomegalovirus infections.
All infectious causes of polyradiculitis you have to consider. Okay. And also you have to consider lymphomas or lymphoreticular malignancies. They can also have elevated cell count. They can also have elevated protein. They can present with sometimes leptomeningeal metastasis presenting as an element syndrome.
Yes. Proceed, ma. Proceed.
General management, the airway, breathing and circulation was managed in this child, and the nutritional support was given through Ryle's tube feeding. Pain management was done for this child. Then skin, bladder and bowel and eye care was given. Physiotherapy was started from the day of admission, and psychological counseling for both child as well as parents were given.
She progressed, bulbar weakness progressed. Why did you start her on Ryle's tube feeding?
Ma'am, initially there was bulbar weakness, ma'am. So we suspected if there is a impending respiratory failure, ma'am. So as to prevent aspiration, we initially started Ryle's tube feeding, ma'am.
Okay.
What about pain management? What did you give for pain?
Gabapentin and carbamazepine and gabapentin can be given, sir, for this for GBS management.
No, for this
NSAIDs,
child, what
gabapentin.
You gave gabapentin or carbamazepine?
Gabapentin, sir.
Okay. Okay. So only thing, amitriptyline has to be used with caution. Amitriptyline, because of its cardiac side effects, This child is more prone for autonomic dysautonomia. So amitriptyline should be used with caution. So you can use gabapentin.
The child was routinely monitored for signs of progression of weakness, ma'am. Daily, the single breath count was monitored 4th hourly. Vitals, heart rate, blood pressure, respiratory rate, and pattern of breathing was monitored to rule out any autonomic dysfunction. MRC power grading was done daily, and the child was monitored for any swallowing dysfunction. Then functional disability scale of GBS was done for this child, and bowel and bladder functions were monitored daily.
What is the disability scale you used? What is this?
Modified Hughes disability scale of GBS, sir.
Okay. What is it? How many scores are there?
It has 6 scores, sir. 0 is healthy. 1, the child is able to do manual work or running. And 2, the child is able to walk across 10-meter space without any support. 3, the child is able to walk 10-meter space with support. 4, the child is bedridden or wheelchair bound. And 5th one is the child is connected to mechanical ventilator, and 6th one is death, sir.
So this child had a score of 4.
4, sir.
4. Okay. Okay. Yes.
The specific treatment which was given for this child was IVIG. It was given at a dose of 400 mg per kg per day for 5 days.
What are the indications to start IVIG in a child with GBS? Will you treat all children presenting with GBS on IVIG?
No, ma'am.
The
indications for starting IVIG, rapid progression of weakness, ma'am. If there is severe bulbar, autonomic, or respiratory involvement, ma'am. If the modified Hughes score is more than equal to 3, then it is an indication for starting IVIG, ma'am.
Okay.
The patient should be presented to you within 2 weeks.
Yes.
Within 2 weeks, sir, IVIG can be started.
So within 2 weeks, yeah.
Yes.
What's the other option?
Other option is plasmapheresis.
So which is preferred, IVIG or plasmapheresis?
IVIG and plasmapheresis both are equally effective, sir. But IVIG is preferred because of it is less invasive and it is safe to use, sir.
Ease of administration.
Ease of administration.
Yeah. But it's costlier when compared to plasmapheresis. It may be costlier.
Yes.
What are the problems with IVIG? Side effects?
The IVIG, it can cause anaphylaxis, sir. In IgA deficiency patients, it can cause anaphylaxis. It can cause aseptic meningitis, sir. If the IVIG is given at a very faster rate, then it will lead to higher osmotic pressure and it can cause renal and cardiac problems, sir.
Okay, good. Yes. How it acts? What's the mechanism of action?
It dimerizes the anti-ganglioside antibodies, sir. It inhibits the production of macrophages and inhibits the complement activation, sir.
Okay. It neutralizes the blocking antibodies.
Yes.
Okay. Proceed next.
Course of stay. The total duration of hospital stay was 53 days for this child. On day 3 of illness, after getting the neurologist opinion, the child was treated on IVIG 400 mg per kg per day for 5 days. The power in the upper limb at initial presentation was 3/5 and lower limb was 2/5 at admission. At the end of second week, the child had weakness in the upper limb. That is, the weakness progressed. Upper limb weakness was reduced to 2/5. However, the child didn't have any respiratory insufficiency. There was no paradoxical breathing. And at third week, the child showed improvement, and the child was able to lift her head from the bed. At fourth week, the child was able to sit with support, and the child was able to turn from side to side. And the child at fourth week, the child regained her voice. At fifth week, the child was able to take food on her own, and the child was able to stand. At the end of 6th week, the child was able to walk without support. The modified Hughes score at admission was 4 and modified Hughes score at discharge was 2, sir.
Okay. So child improved in 6 weeks time.
Yes, sir.
So with only IV immunoglobulin, child didn't go in for any ventilator support. Okay.
Yes, sir.
Okay. Mhm. So how to assess the prognosis? Suppose on day 1.
Sir, Erasmus GBS outcome score can be done to assess the prognosis.
So it's based on?
Based on age at onset of the weakness and preceding if there is any diarrheal disease are present or not, and based on the MRC grading.
Yeah, total MRC grading. What is the score, maximum score?
If it's the score is less than 3, there was good outcome. If it is more than 5.5, there will be 50% chance for residual motor and sensory deficit.
Okay, so score varies from 3 to 12.
Yes.
Okay, so higher the score, the higher the risk of disability. Okay. Okay. Anything else, madam? Yeah.
What are the variants of GBS you know of?
AADP, ma'am.
This is the electrophysiological types you're saying,
yes,
no?
ma'am. Yes,
okay.
AADP, Amman, Amsan variant, and Miller-Fisher syndrome, and acute pan dysautonomia, acute ophthalmoparesis, and pharyngocervical brachial weakness, ma'am, and polyneurative cranialis, ma'am.
Okay, what are the atypical variants? Classical sensory motor is the typical variant. What are the atypical variants?
Paraparetic type, ma'am, and bifacial weakness with paresthesia, ma'am, and
pure sensory, pharyngeal cervical brachial.
pharyngeal.
So what is the classical triad of Miller-Fisher?
Ataxia, external ophthalmoplegia, and areflexia, ma'am.
Okay.
So which type is common in India?
Amman variety, ma'am, sir.
Amman is common in India, yes.
So what antibody titers can you check in patients with GBS, provided you have the lab facility?
Anti-ganglioside antibodies.
In 20% of the patients, anti-ganglioside antibodies, GM1, GM2, GD1A, GD1B, GQ1B, GT1A, ma'am.
Okay.
So antibody testing is not necessary for diagnosis.
Yes.
So if facilities are there, can be done, but it's not necessary for diagnosis. So diagnosis is mainly by clinical. Electrophysiology help. It's only an extension of our clinical diagnosis. It helps in classifying the type of GBS. Electrophysiology helps in prognosticating the case. Which type has got better prognosis?
AADP has better prognosis, sir.
Yeah, AADP better prognosis. Amman slightly poor prognosis. Amsan still poorer prognosis. In this case, you have not mentioned about the other workup. You have not mentioned anything about AFP workup. Have you sent the stool sample for
yes, sir. The
poliomyelitis?
Yes,
you
sir.
mentioned
The stool
everything.
sample.
Yeah.
Stool sample, stool reporting for AFP was sent for this child, sir. 2 stool samples at 24 to 48 hours apart, taken within 14 days of onset of paralysis, sir.
You sent the sample?
Yes, sir.
Okay. Okay. So sample should be sent in the cold chain.
Yes, sir. 2 to 8 degrees Celsius.
Okay.
When this child has recurrence of weakness, she has recovered completely, and then she presents with recurrence of weakness again, similar symptoms. What are the differentials you think?
Treatment related fluctuations, ma'am. If after initial stabilization or improvement, if the child shows worsening within 8 weeks of presentation, then treatment related fluctuations can be considered as one of the differential diagnosis, ma'am.
Okay.
If treatment more than 3 treatment,
CDP can manage.
Yeah, CIDPS. Recurrence of GBS, has it been described?
2 to 5% chance of recurrence of GBS is present, ma'am.
Okay. So what is hourly managed treatment related fluctuations?
Second course of IVIG or plasmapheresis can be given, ma'am.
Okay. So if you're treating a child with GBS and after the first course of IVIG, child is on mechanical ventilation and quadriparetic and has not shown any improvement, will you try a second course of IVIG?
No, we can wait and watch for the response of IVIG.
If there is worsening of the symptom,
there is worsening of, if there is no improvement after 2 weeks, can be one course can be repeated. Either IVIG or plasmapheresis can be repeated. You can repeat another course after 2 weeks if there is no improvement or if there is any worsening. Another course of IVIG can be repeated, or you can give plasmapheresis also. Either IVIG or plasmapheresis can be given after 2 weeks. So what about combining both IVIG and plasmapheresis? What is your comment?
There is no synergistic effect on combining. Both are equally efficacious, sir, and there is no synergistic effect in combining both IVIG and plasmapheresis, sir.
Yeah, combination is not useful. Yeah. Wow. So what about role of steroid?
There is no role of steroids in the treatment of GBS, sir.
Okay. So steroid is not useful, but it may be of some use in reducing the pain. Steroids, but there is no study. There are some reports that steroid may be useful in reducing the pain symptoms, but it's not useful in improving the power. Okay. So how do you manage the autonomic disturbances in GBS?
For hypotension, fluid correction can be given, sir. But in case of hypertension, the GBS usually presents with a labile hypertension, sir. So we must not use antihypertensive, but if needed, short-acting antihypertensive may be used, sir. But long-active antihypertensives are not advised for this child, sir.
Okay, what's a short-acting antihypertensive?
Nifedipine, sir.
Not short-acting. Yeah, you can use esmolol, nicardipine. Esmolol can be used. Esmolol. Okay. Okay, what about polio vaccines now? What is your which vaccine you are giving now? In killed vaccine or oral vaccine? Oral vaccine. Yeah. Why it is bivalent?
Sir, the type initially trivalent vaccine was given. Strain 1, 2, and 3 both were included, but at present on 2016 it was changed from trivalent to bivalent, sir, as the strain 2 is associated with
vaccine associated
paralytic poliomyelitis.
Okay. Okay. So when was the last polio case reported in India?
2011, 14, sir.
2011 lastly reported, sir. 2014
polio free India.
Okay, it was reported in 2011, last case. Yeah. Okay. Anything you add, Madam? Dr. Sangeeta, Dr. Raji?
No, sir, no further questions. I think the team has done an excellent presentation.
Dr. Raji, Madam?
Nothing, sir. What should we say about that? I think they've covered everything.
So there is.
This is the way to got the child for follow-up.
They presented very well. So any questions are there from the listeners?
Only appreciations. No questions, the chat box or the question answer.
Questions are there in the chat box, doctor.
Some question. Can you think of minimal respiratory muscle in weakness in view of upper limb involvement? Can you think of minimal respiratory muscle weakness in view of upper limb involvement? Yes.
Yes, sir.
There is some shoulder abduction weakness. Child is likely to have some impending respiratory muscle paralysis.
Yes, sir.
Shoulder abduction is C5. So diaphragm phrenic nerve is the C3, C4, C5. So child is likely to have respiratory muscle involvement or impending respiratory failure is there. So that's why in any case of GBS, you have to see for upper limb involvement, shoulder abduction, and neck muscle weakness should be looked for. If there is neck muscle weakness and even trapezius weakness also can be looked for. Trapezius, again, the root value is C3. So if there is trapezius weakness, shoulder abduction weakness, neck muscle weakness, child is likely to have respiratory muscle weakness. Child can develop respiratory muscle weakness. Yes, sir.
This question was specifically asked. Just wanted to know whether one of the reasons for weak voice can it be a respiratory muscle weakness other than the bulbar weakness?
You are not very clear. Can you keep the mic near?
No. What's your question, sir?
Can hypophonia, which was mentioned, the weak voice, that means the bulbar muscles can be totally normal. Can it be just due to a respiratory muscle involvement?
Yeah, definitely. Yes, it could be due to respiratory muscle weakness also. Could be due to Yes, sir.
This question asked is generally for postgraduate level, for GBS, they mainly want to, test them for respiratory muscle assessment.
Yes, sir.
Like intercostal weakness, diaphragmatic weakness, those things are, and other, of course, single breath count. Those are all the things which are generally asked.
Yeah. The hypophonia could be due to respiratory muscle weakness. Yes, could be. Anything else? How to grade power of trunk muscles? How to grade power of trunk muscles? Trunk muscles power is not graded. Axial muscles are usually not graded. Neck muscle, trunk muscle, only thing we can say weak or not. Axial muscles are not graded. Power is not graded. Even hand grip also we can't grade. Axial muscle power should not be graded. Tongue fasciculations. What is the question? Tongue fasciculations.
I had asked that, sir. I was wondering whether from head to foot examination itself we have to mention instead of waiting for cranial nerve examination to tell about tongue fasciculations. That's why I had asked. Or whether they need to wait till the cranial nerve and then mention the tongue fasciculations.
Can be mentioned in the cranial nerve examination, madam. It can be mentioned in the cranial nerve examination.
Okay.
Tongue fasciculations, usually it is more relevant in chronic anterior horn cell diseases, chronic diseases.
Mentioned it during the cranial nerve, but head to foot also, when you're looking at the mouth and all that, it's not possible to miss if it is there. So that's why I asked.
Okay. Can lead poisoning present acutely?
It can be present as motor neuropathy, sir, like wrist drop and foot drop.
Acutely, that is the question.
No, sir.
Yes.
No, sir.
Usually patient will have other features. The patient present with the neurological
abdominal pain.
Yeah, abdominal pain, sometimes the encephalopathy, lead encephalopathy.
Yes.
Anything else, sir?
Can wind up, sir.
Any other questions?
Yeah. That's Sangeeta.
Yes, sir.
Yeah, any question?
No further questions, sir.
Okay. Dr. Srinivasan, sir, please comment, sir.
Sir has already placed his.
Yeah, I already placed my comments. Yeah.
Okay.
So I enjoyed thoroughly and I learned a few things from all of you. Thank you.
Dr. P. Ramachandran, sir.
Sir, just as Professor Srinivasan said, I totally agree. And all the three postgraduates were equal to the task. That is very surprising. Okay, so none of them was anyway any less than the other. So they are all equal to the task. And the barrage of questions which came from the neurologists, they were able to answer so well. So it's really very heartening to see them prepared so well and to answer so well. So congratulations.
Be prepared to take up neurology, right? Pediatric neurology.
Yeah, Dr. Ramesh, Dr. Ramesh.
I didn't see him, sir.
Dr. Rama, madam.
I don't know whether I think it's probably the best presented case by the PGs, and of course the neurologists are specialists and their questions were excellent, but I think the PGs were really, really good. Congratulations to all three of you. You were, I mean, sometimes the examiner didn't even thinking what question to ask these people next. Like that, you were up to date, up to the fingertips with all your answers. Excellent. Congratulations to all of you, to your mentors who, whether you're prepared on your own or with your mentors' help, you have done an excellent job. And Velusamy sir and Sangeeta, both of you have, Raji also, brought out all the relevant points which are needed for the exam and also for all, GBS in general. So overall, it was a very comprehensive presentation. Thank you to all of you for all the learning points that we have gained today.
Thank you.
Thank you. Dr. Janani, madam. Dr. Janani. Dr. Velusamy, sir, any please final comments, sir.
Yeah. Congratulations to all the postgraduates. They have done excellent presentation. Congratulations to the mentor also, Dr. Raji. Presentation is very good. It's like a neurology presentation they have done. I congratulate them and all the best. I once again thank IAP Tamil Nadu State Branch. I once again thank Tamil Nadu State Branch IAP for giving me this opportunity.
Thank you, sir. Dr. Raji, madam. Yeah.
Can they stop sharing so that we see the others?
Hello. Good evening, sir.
Valliyamai, please stop sharing, Valliyamai.
Yes.
Madam, please proceed, madam.
So on behalf of IIT Tanjavur and Department of Pediatrics, I extend my thanks to you, sir, and the office bearers. And I thank my HOD for giving me an opportunity to give this postgraduate session, sir. Thank you, sir.
Yeah, thank you, madam. On behalf of IAP TNC, I really thankful for today's great presentation and the leadership of Dr. Selva Kumar, and he is he's a taskmaster, and he has made his postgraduate prepare very well. I thank Dr. Raji Madam to make their students prepared very well. And on behalf of IAP TNC, I thank all the judges, Dr. Srinivasan sir, Dr. Ramesh sir, Dr. P. Ramchandran sir, and as well as Dr. Ramachandra Mohan, Dr. Janay Shankar. They are throughout that session, they are participating, they are giving very valuable comment also. And again, I thank all the judges. I thank today's chairperson, Dr. Velitsamy sir, and Professor and HOD, Department of Neurology, Government Kilpack Medical College. I think it's an excellent discussion today. And I thank our Dr. Sankira Yoganathan, Professor of Pediatric Neurology from CMC Vellore. And on behalf of IAP TNC, thank again all the students from Tanjavur, Valliyamai, as well as Kalayarasi, Sai Surya. They are excellent. As Rama Madam said, it's an excellent case discussion, and it was one of the best presentation. And again, on behalf of IAP TNC, I thank all the delegates as well as teachers who is watching this program all over India. And thank you, Ananda. Thank you.
Thank you. Good
Thank
night.
you.
Thank you, sir. Thank you, sir.
Thank you.